Thanks, Nick. I might get the panelists to turn their videos on. And if you've got any questions, if you can put them in the question and answer box, that'd be great. We have one question already from Dan, and this is to Sid. How do you encourage people to get into the errors mindset?
Thanks, Dan, for the question. It is quite a good question. And I suppose getting people into mindset is all about setting patient expectations. And that starts very much from the preoperative phase of things, getting patients ready to go home after surgery, educating them about what to do after surgery. And also it's important to have everyone on the team on board to make sure that they're reinforcing the idea that patients are not going to stay in hospital for what they may traditionally think, joint arthroplasty patient may stay in the hospital for. And it just sort of takes that one person to say something backhandedly, or just as a runaway comment to say, you're staying in here for not as long as you may need to, or something like that, which can get patients really offside and sort of cast doubt into whether they can go home early after surgery.
I had a question for Lyndon. Lyndon, I noticed that there was a difference between patients undergoing joint replacement and those that aren't undergoing joint replacement in terms of their mobility and activity. Why do you think there is a difference between the two groups, even though after joint replacement, it still seems to be a difference between the groups?
Yeah, that really is the question when it comes to physical activity after joint replacement is, why is that disparity between people who are in the general population and people who've had the joint replacement? Why don't those activity levels normalize after joint replacement? And I think the answer is it's multifactorial, but a lot of it comes down to habit. I think a lot of it comes down to people have just been so used to reduced physical activity levels during the time that they're experiencing the arthritic symptoms, where there's been quite significant pain, quite significant joint dysfunction, that even though those factors have been addressed in the surgery in most occasions, for some reason they just don't get back up again. And I think a lot of it has to do with habit. They've just got into the habit of not moving enough. And so when they've had a good outcome, those habits of low physical activity perpetuate. And it's turning it around. And I guess another sort of big factor in that is they don't realize that they're low. They think that they're doing as much as they did beforehand. And so that they're not doing as much and they don't realize it. And that's a real double whammy. So when it comes to how to address it, there's no one quick fix and no one answer. Again, it's a multifactorial, but that would be my take on it as why there is such a big difference between people who have had a joint replacement, people who haven't, and why that disparity in physical activity remains.
Thank you.
We've got some questions in the Q&A box. So this one is also for Sid, and it comes from Jonathan, who said, great presentations, everyone. My question is, part of the ERAS, is prehab encouraged, or is there any evidence to support that it improves outcomes post-op?
Thanks for the question. At the moment, a number of systematic reviews have been done around the idea of prehab or pre-rehab for arthroplasty, including which have included randomized controlled trials as well. And none of those have actually supported the idea of pre-rehabilitation for arthroplasty. In other forms of surgery, like abdominal surgery, where ERAS is also performed, pre-rehab is encouraged and does connote better outcomes, but not so much for arthroplasty.
And another question for Nick. You mentioned we need to ensure optimal preoperative care if we are to get people home early. Are there any pitfalls you fear a health system? Are there any pitfalls you fear a health system, health service, or health professional would fall into, i.e. not provide optimal preoperative care?
I think Nick's just joined the panelists, so we'll just give him a second to get on. There we go.
Sorry. There we go. I'll ask again. Hi, Rob.
you.
Just a question for you about your presentation. So Christian Bard has asked, you mentioned we need to ensure optimal preoperative care if we are to get people home early. Are there any pitfalls you fear a health system, health service, or health professional could fall into, i.e. not providing optimal preoperative care?
I think the thing that struck me was really the importance of the team, and that Sid talked about in detail about ERAS, that it was, and often we look at things from our own perspective, particularly as from my case, from a physio point of view, and you can see that when it works, you're just one part of a much bigger team. And when that's done, that works really well. I think when people are trying to do something in isolation, not part of the team, that's when there would be problems. The other thing which I was kind of wondering about that didn't really come out much in the literature were the consequences about what if getting people home very early in terms of their post-operative care, particularly from my point of view in terms of their rehabilitation and physio. And that really wasn't addressed much in the literature, except very much indirectly in that there don't seem to be any differences in costs and post-operative contacts afterwards.
Thank you. And I've got a similar question for you, Prof. Taylor. You said there was a selection bias in a lot of the studies, and I tend to agree that there tend to be younger, fitter patients, but it didn't show a difference in terms of complication rates and adverse outcomes. So I guess the question is, if there's a selection bias and they're better patients, but there is no difference in adverse outcomes, could it be that they've actually got a higher adverse outcome rate, but because they're better patients to begin with, that's just not being picked up in the literature?
It's absolutely, it's possible, but in some, that would be counterbalanced by that in some of the indices of adverse events, they actually went a little bit better in terms of readmissions for, I think it was hip replacements, for example. And the other thing, also the one randomized controlled trial that's been published that I could locate reported results consistent with a really large case series. And the other thing that struck me was the fact that although there is a selection bias and the patients tend to be younger, they're not that young, really. Like the majority in the US were the most frequent, were mostly in the 70 to 79 age group. So it wasn't like it was like people who were dramatically younger. But it's a really good question, and I think that there is that selection bias, and so it's still, that would really only be addressed by doing some larger randomized controlled trials in this space.
And another follow-up question, what do you think is the biggest roadblock in Australia for getting patients home early?
Well, I might put that back to you, because you're sort of closer to the coalface, Sina, and so, and also I kind of speculated whether there might be some funding incentives, and also I wondered whether it's just partly cultural, it's just what we're used to, and I wondered whether in fact it's also perhaps in the US they have these specialist centres which sort of focusing on joint replacement surgery, and that enables it's kind of easier to set up the team there and have that focus. But I'd be really interested to get your insights on that one.
I kind of agree with all of that, to be honest. And I think it's just getting that cultural shift amongst all stakeholders. It seems to be the hard bit, getting, you know, the pre-op, physio, anaesthetists all on board at the same time, the same enthusiasm. America was driven by the health insurers, and they kind of got everyone on board at the same time. And I think in Australia, we all seem to be firing at different times, and we haven't all having to fire at the same time, but that's just an anecdotal observation. And
I think also the thing was that it's really clear that, you know, just because you can do it as outpatient surgery doesn't mean you have to. You know, like if you can do it, if people can be discharged on day 1 or 2, that's obviously, and it can be done very safely and possibly with some benefits, then perhaps doesn't necessarily have to be outpatient surgery.
Yeah.
Just because you can do it.
Yeah. Good.
We have a couple of questions for Emma. So Emma is joining us as the APA representative. Emma, how has the APA supported physios during COVID-19 lockdowns with the shift to telehealth interactions? And then there's a kind of a follow-on. Have the APA looked at the economic values around telehealth versus face-to-face?
Yeah, actually, the APA has been working extremely hard, working with the governments to basically to see physio as an essential service during the COVID lockdowns, and they've always provided information to everyone, you know, straight away as soon as these lockdowns happen. I mean, they happen pretty fast, and so we get that information through a number of different methods, social media. So yeah, they have been really strongly advocating for this for quite some time, obviously over the last 18 months. This has been happening. Yeah. And
is there any plans to do sort of any economic analysis of the cost benefit of telehealth versus face-to-face, or is that, because you've done that for 11 different examples we heard, so is there any plans to do that for telehealth, or are there others that are more important? Yeah, I would imagine so, because that is definitely telehealth has been we've moved to telehealth, you know, a lot over the last 18 months, and it's shown that that's a really good way of being able to deliver some of these you know, services during this time. So yeah, I would imagine so.
And we've got one for Sid from the ether. If you have surgeons that are reluctant to send patients home early, how can we get them on board to reduce length of stay?
Yeah, that's a really good question. I think pertinent for Australia. And I think partly to answer that question, you have to look at ERAS as not only like a mindset, but also as a way to shift incentives for surgery. So looking at other health services in the world where there's a significant cost burden on the patient and the health service if you stay in hospital for longer lengths of stay. Hence, the incentive is to actually get patients out quite early. In Australia, it doesn't seem to mirror those sort of connotations where the incentive is maybe to actually stay in hospital for a couple of days, 3 days, as compared to get out as early as possible. So if you're able to sort of shift those incentives and encourage surgeons to get patients out of the hospital quicker, you know, you could get through more patients in that are able to have a joint replacement surgery and also have better outcomes as well.
Yeah, a follow-up question from me is, have you found any surgeons who are reluctant to get their patients home early?
I don't think so. But it'll be certainly a study that I'll be conducting for my PhD to get surgeons' opinions around length of stay and the desire to buy into programs such as ERAS or something similar.
I think I might have a question for Sid and Nick at the same time. So Sid, in your presentation, you mentioned that one of the important parts of the ERAS surgery is the education that happens prior to surgery to reduce anxiety in patients. And I just wondered with the day surgery, whether that could potentially increase anxiety in patients and whether that has an impact on the patient-reported outcomes from patients after sort of day surgery or really short length of stay. So it's kind of a question for both Sid and Nick there. I know that Nick said that he couldn't find that much patient-reported or patient functional outcomes, but if you could both comment on that, that'd be great.
Yeah, I'm happy to go first. Yeah, so I don't think I haven't been able to find much information on patient-reported outcomes for outpatient surgery, but there have been quite large national health service reviews, one of which was for the UK, which showed as length of stay was decreasing over time. I think it halved over a period of 10 years. The patient-reported outcomes either increased or there wasn't a significant difference as length of stay changed. So I don't think patient-reported outcome, I don't think you could reduce length of stay at the sake of reducing patient-reported outcomes as well. I'm not sure if length of stay directly would correlate with that. I'm not sure, Nick, would you have any other thoughts?
I guess my thought was about expectations, and setting up expectations is really important. And the way I started my talk was just when I graduated, it was the expectation was that you'd stay in bed for 7 days until you got up the first time. But the really progressive radical surgeon where I work got their patients up at day 5. And so that was sort of pushing the envelope a bit. And you just think, looking back now, you think, wow. So I think a lot of it is, I would think, in the education would be setting up expectations. If that's what you expect to happen, then that's going to go a long way towards addressing anxiety in our patients.
And another question from Estelle. So the question is to Prof. Taylor, me, or Sid. And she's just wondering what we envisaged a multidisciplinary team would look like to manage patients having outpatient arthroplasty in Australia at home. Is it more a hospital in the home model, a rehab in the home style team, or a nurse-led model, or something else? I can go first with that. In my mind, again, it's a multidisciplinary type scenario where you would definitely need physio in the home and potentially initially nursing staff for wound care management, etc. So I think it's basically the things you have in hospital, i.e. nurse and physio, but visiting once a day or via video or something similar is what I see it as being in the long term. Sid or Prof. Taylor, would you like to add or subtract?
Sure. And a lot of the US programs that have been set up internationally have always been a nurse-led or having a nurse coordinator who's leading the program. So patients I usually, see a lot in a multidisciplinary team preoperatively, get their work up, and then postoperatively have contact details for nurses who they can liaise with if there's any issues or any problems. So in my mind, it'd be, as you were saying, a multidisciplinary team, but probably a nurse-led approach.
Yeah, that's fine. I don't have anything to add to that. And certainly in the literature I was reading, there was sort of light on the detail about how it was actually done, that aspect of it.
There's another question here from Dan. Do you think that patients will be receptive to reduced length of stay, even clinicians and hospital administrators, etc.? Will they all be on board?
I can perhaps tell a little story here. Where I work, there was a story. I think there are a lot of expectations and there are some sort of perverse drivers. And I hope this is answering the question. It's probably a bit indirect, but this anecdotal, there was a place where I work at one of the hospitals, then the physio is getting very frustrated because the physio is finding that her patients were ready to go home at like around about day 3, but at that stage, they're getting transferred to inpatient rehab. And because there was an incentive for that ward to kind of get the patient throughput and to keep and so once, of course, they get to rehab, it takes a while for them to be processed. And so this is like a perverse incentive. So it's kind of good for that ward to get them home out of the ward by day 3. So yeah, I think there are problems across the system in order to get it in place. Hopefully that partly addresses the question. It's a good story anyway.
It's a great story. Does anyone have anything else to add to that?
I suppose the only thing I could add in is, as we've been talking about before as well, just about setting expectations of patients, probably the most important bit. And then again, to try and shift the incentives for clinicians and particularly hospital administrators to see that reducing length of stay can actually be a benefit rather than be sort of something that just reduces the bottom line particularly for a hospital.
I've got one more thing to add to that. I visited, and there's an anecdotal story, I visited Switzerland, and over there they usually stay 5 to 7 days. Talking to the surgeons, they say that the Swiss, because they pay so much for health insurance, they demand to stay at least a week, get good food and warm bed. So again, I agree with Sid that patient expectation plays a huge role in all of this.
sounds like something we can all work on, which would be great.
Mm.
I've just got one question for Lyndon as well. Lyndon, I think you've identified a really important gap in what we know about in care for people after surgery. So I'm pretty excited about where it's going to lead. And I just wondered if you've got any ideas about where you might head with the intervention, or I mean, I don't want you to sort of burst the bubble, but just if you've got any ideas about where you think it might head. You mentioned that you were thinking about looking at some patient-led sort of intervention as well.
Yeah, there's a couple of ideas about how to best address physical activity after joint replacement, or the lack thereof. But it's a really exciting and really brand new area of research. There just hasn't been much done in that space up till now. And it's really interesting when I was going back and looking through the evidence around, or where the sort of like focus was on these sorts of trials and studies and what have you. And you can see, like, from about 10 years ago, everyone was focused on, is there a difference between physical activity between joint replacement, before and after, and compared to people who haven't had any issue. And that's where the focus was. Is there a difference? And now that has been well and truly answered, yes, there is a difference. And about 5 years ago, you could just sort of see the tide turning as to, okay, so what do we do about it? And there hasn't been a whole lot done in that space. I think there's been maybe 5 or 6 studies, all of which haven't had a really great result about what definitively can be done to effectively increase physical activity after joint replacement. A lot of people, a lot of researchers, a lot of clinicians are saying behavioural interventions are the way to go. But even when behavioural interventions have been studied in randomised controlled trials, it's just at a very early stage. And again, there hasn't been the results there to definitively point a way forward. So what we're looking at is, okay, where we identified one of the biggest blocks was knowledge. Okay, and when you look at the behavioural change intervention, like how those steps of the behavioural intervention, how they actually work, right at the very beginning, the first step is knowledge of the health behaviour. And as I said in the presentation, that is really key, because if there's no knowledge of the health behaviour, people don't have an incentive to change that health behaviour. So that's where our next project is going to lie, is actually on that focus of, okay, so how can we effectively increase knowledge of physical activity after joint replacement? How do we go about that effectively? That's a really big question. So where we're starting is, okay, co-design. Let's have a look and see if people who have actually been in that situation have any ideas about how best to communicate to them or to other people in that same population. What do they think is the best way of increasing knowledge? So it's certainly not a guaranteed of success, but we feel if you look at the evidence, that's a really good place to start. So hopefully that answers your question, Jodie. We're going to be looking at co-design to see if that makes any inroads in increasing knowledge, and then laying the foundation for an effective way forward for the behaviour change interventions to take place effectively.
Sounds great, thanks.
We've got one more from Christian for Lyndon and the rest of the panel. Is there a problem with physical inactivity? Is the problem with physical inactivity, or the solution perhaps at a system level rather than individual, i.e. infrastructure, town planning, community groups, etc.?
Yeah, that's a really good question, Christian, and I probably don't have the answer to that. It seemed to be that the fact that people weren't getting knowledge about physical activity happened to be occurring at numerous levels. So people just weren't getting knowledge from the general media, from general, what would you say, just general information that they would come across in their normal lives. A lot of people, for an example, a lot of people said, we need something like the Life Be In It campaign, or the Slip Slop Slap campaign from back in the, the 80s. That's something that they still remember, and that's something that they really resonated with. And they don't feel that that is available in the community at the moment, that sort of information. And so that's probably a failure from like a government perhaps level, in terms of getting the information about physical activity out there, especially in Australia. But then also there was difficulties with communication from their health professionals as well. And they were quite very clear in saying that they weren't getting this communication from anybody that they talked to. So and that included their surgeons, their medical team, their therapists, the nurses, so their GPs as well. So they were really getting really poor information about physical activity along their whole journey that they took through the health system to have their knee replacement. Having said that, when you say infrastructure, town planning and community groups as well, a lot of people that I spoke to were actually involved in those sorts of community groups already. They did like Tai Chi, the U3A, they went to local exercise groups and those sorts of things. And even then they were still lacked the basics about physical activity in terms of the intensity, the dosage and what have you. So even then, when they're linked into those sorts of supports, even then the system does seem to be failing. So there's multiple areas why I think this the knowledge is not getting transferred to these people, and that makes it really hard to do something about it, but at least we've got to start trying.
Yeah, I think Christian, I don't think that environmental factors are barriers as such, or are not the key barriers. I think the barriers are attitudes and knowledge at the level of individual people and their therapists and medical staff. It just doesn't seem, there always has been, and I think there still is such a focus on addressing the impairment with total knee joint replacement, which makes sense. It's a knee joint replacement. So it is an impairment. It is an impairment intervention. But I guess the thing, and to kind of, I think why Lyndon's work's so important is that people don't die of knee OA, but they do die of cardiovascular disease. And sure, the knee OA needs to be addressed, and it's addressed really well with joint replacement surgery, but there's a bigger picture that's really important, is people's broader health. And that's what's important. And I think so we're so focused, a lot of us are so focused on addressing the knee and treating the knee. And that's important, but it shouldn't stop there.
And one final question for Emma. Are there any known high-value common physio practices that are not currently being utilised?
Yeah, I would say that there isn't physio practices that are not being utilised. I just think that the ones that, some of the ones that are that we do know are highly evidenced, like exercise and OA, are probably just not utilised as much as they could be. And I think what I see is that a lot of patients are referred directly to surgeons for their knee pain. And I think the fact is that if patients were able to be referred, or if patients were referred more from GPs to physiotherapy directly first, then we know that potentially might change where they go in terms of whether they head towards joint replacement or whether they're able to avoid it. So I think that, yeah, the APA is working really hard at advocating for physiotherapy with the government and the way that's funded. And as they continue to do that, I think that will help those services to be utilised more.
Perfect.
Great.
No, I think we're going to call it and move on to the next session. Thanks to all the panelists for joining us, and hope the audience got something out of it. Thank you, guys.
Great.
Thanks,
Thanks again to
everyone.
all panelists and all the chairs. I'll hand over now to Rita and Jason to take us through the final session of the day on ethics.